could take our seats, we'll get going. That's Arnold Brody down there. I've asked him not to sit next to me. And I'm Marvin Schwartz, and our first speaker is Ivan Rosas from Boston. And he's going to tell us about subclinical ILD and why we should care.
Yeah, thanks, Marvin. Thanks, Arnie. I want to thank Luca and all the organizers of this fantastic meeting. And I'm going to talk today about subclinical interstitial lung disease and why you should care. Or some people say, well, should I really care? What you're showing me, is it interesting? Is it important or not? So I'm going to try to convince that we have a phenotype that may be worthwhile studying in the future. I have some disclosures. And basically, this question that we've been asking ourselves is a question that's obviously been around for a very, very long time. And you can go back to 1899 when Sir William Osler was doing some descriptions of the changes of IPF lungs. But it's interesting because while he was making these descriptions, I actually found a couple of references in the literature suggesting that in familial pulmonary fibrosis, there were already descriptions of siblings who had had radiographic changes prior to the development of symptoms. In particular, two sisters, one of which died, and then they looked at their chest x-ray 10 years before dying, and there was already a presence of fibrosis. So this is the problem that we're dealing with, and I'll try to give you some definitions, but really the definition is something that's growing with time and as we become more experienced. So in the clinical setting, I think subclinical interstitial lung disease encompasses groups of individuals that have specific radiographic, physiologic, and in some cases, histopathologic abnormalities, but these individuals are actually asymptomatic. Now, Marvin was just telling me that he's seeing these patients forever, and I think most of you who actually do clinical interstitial lung disease have had the opportunity to see these patients who really had CT scans in the past that showed definitely interstitial changes, and in some cases, changes that were typical for IPF, and they're coming to your clinic a couple of years later. But for the purposes of research studies, we refer to subclinical interstitial lung disease in undiagnosed individuals who have, we call them interstitial lung abnormalities, that are defined mostly by chest computed tomography, that are consistent with, but definitely more subtle than those that we observe in patients with established interstitial lung disease. And many of you sitting in this room basically helped us understand interstitial lung disease by this classification. And so I won't belabor on the details of the classification, but we don't really know what subclinical interstitial lung disease is and if it really belongs within this classification. Some of the reviewers of our work basically think that this is really DIP or RBILD, and some others actually agree that subclinical interstitial lung disease may be precursor of other conditions like NSIP or UIP, and there's a scant surgical literature that suggests that some patients with subclinical interstitial lung disease changes will go on to have these acute exacerbations that were referred to earlier today. So in this review that Moises, Annie, and Talmadge wrote, I think they're depicting very well what we're talking about. Basically, most of us practice here, but what we're going to be talking about today are these individuals with asymptomatic interstitial lung disease, the asymptomatic period. And so why should you care? Well, I think there's a growing interest, and this question did not begin today. As I told you, there are references in the literature that go back 100 years, but Peter Bitterman in 1984 had specifically asked this question and did some phenotyping in familial pulmonary fibrosis and definitely described this presence of subclinical interstitial lung disease. And since then, there's been quite a significant amount of work from our group and others trying to characterize the disease, and what I'm going to focus today is on familial pulmonary fibrosis, on connective tissue disease, specifically rheumatoid arthritis, and there's quite an excitement about looking at this phenotype in smokers. And this is summarized in a perspective that Tracy Doyle wrote earlier this year. Another reason why you should care is because really the Division of Lung Diseases at the NIH is acknowledging that we're behind what other fields of medicine have done in terms of primary prevention. So as you know, in cardiology and in oncology, there's a lot of focus in trying to do at least secondary prevention, but with the goal to ultimately be able to understand this disease enough that we can do primary prevention. And in the summer, I was invited to participate in an organizing committee that's going to put together a strategic plan conference in 2013, trying to look at these strategies. And it's very interesting because Carol Blaisdell asked me, so who's the expert in primary prevention in interstitial lung disease? And of course, I don't know everybody, but it was really hard for me to come up with a name of somebody who's really focusing in this area. I know a lot of us are focusing on this secondary stage of the prevention, and I know all of us are focusing on all these aspects of research that are outlined here. But I just want to say that we should care, because really the Division of Lung Diseases at the NIH, and I'm assuming other funding agencies around the world, want us to tackle the disease earlier than what we're doing right now. So our research question was inspired by this paper from Talmadge in 2001, in which he basically looked at the survival curves that we're all very familiar with. And what struck me was that if you actually asked the patient when they had symptoms, their survival magically doubled. And so you could do the same thing for subclinical interstitial lung disease, or if you had some other ways of phenotyping patients before they actually developed the symptoms, maybe we would be talking about a different window of disease, and that's where the work started. And so the first thing that we did was we hypothesized that if we actually recruited families affected with pulmonary fibrosis, we would be able to identify asymptomatic individuals that had changes in their CT scan. And so this is a 60-year-old individual who actually lives in the West Coast, or at that time was living in the West Coast, and during exercise actually experienced some shortness of breath, but overall had no negative impact on his performance status. And most of you who are actually familiar with CT scans can see that there are some fine interstitial changes that are not classic for IPF, but in a patient with a history of familial pulmonary fibrosis, this is probably an idiopathic interstitial pneumonia. And then this is his brother, who was 10 years younger. By the way, this prior patient was a smoker. This is a non-smoker. And again, you can start seeing these very subtle changes in this CT scan that suggest that there's interstitial lung abnormalities. And when you actually do pulmonary function tests on these individuals, it's really not helpful. And let me show you why. If you look at the percent predicted DLCO, which I thought would be sensitive, and you then divide the group in individuals who have a normal CT scan, patients who have non-specific changes on the CT scan, or patients who have these early interstitial lung abnormalities that we're talking about, there was really not a striking difference in their diffusion capacity, and most of the individuals actually were in the normal range, which is obviously very different from what we see in individuals with disease. There was a subset of patients here that actually did have a decrease in their diffusion capacity, and actually when we looked at their smoking status, that I think explained most of the differences. So definitely smoking, as I'll show you, is an important part of this whole problem. In a subset of individuals, 9 individuals, we actually had opportunities to do lung biopsies, and this is a very limited data set, but what we saw was that in most individuals who were normal PFTs, we were seeing non-UIP histologies, and individuals who actually had mild declines in their DLCO or other pulmonary function abnormalities, we were seeing UIP histology. So this is not a true across the board, and I think that the best data set actually comes from David Schwartz's group, in which he's looked at hundreds of families, and he also reported, I think, an 8% of individuals who had subclinical interstitial lung abnormalities. And his manuscript, he basically taught us that 50% of the individuals with familial pulmonary fibrosis have non-UIP histologies. So I think that this is actually consistent with that finding of a larger study or a larger cohort. And of course, I actually did some of my initial training in Naftali's lab, and so we had to do microarrays, and this microarray is just to show you that some of the broad gene expression signature changes that you see in patients with IPF, you're also seeing in patients with interstitial lung abnormalities. And so we're seeing some molecular changes that also suggest that these early changes, histologically in terms of expression arrays, suggest that this could be a precursor of IPF. And of course, also being in Naftali's lab, I had to look at MMP7. And so we measured MMP7 levels in the peripheral blood, and as you can see, it's very interesting because if you look at the concentrations of MMP7 and you look at those individuals with early interstitial lung abnormalities, there was an increase that was significant when you compare to controls and was not as large a difference as you saw in individuals with familial IPF or sporadic disease. And we also actually, in this subset of familial disease, were able to show some degree of correlation between changes in FVC and DLCO and the MMP7 levels. So again, other molecular features of this clinical phenotype. So what we concluded from this study is that 20% of the individuals that we actually studied had asymptomatic interstitial lung abnormalities, and smoking was a very important risk factor for this phenotype. So as you would expect, 70% or so of patients with familial disease had a history of ever smoking. 45% of individuals with asymptomatic interstitial lung disease had a history of smoking, which was significantly different from controls. And then the other thing that's probably not surprising is that age was a factor related to this. But the question was not if age is a risk factor, but how early can we actually start seeing these changes in these patients? And it's very interesting because there's probably a 20-year lead time between these interstitial lung abnormalities and developing the phenotype of familial pulmonary fibrosis. And so this age of 67 is very reminiscent of the mean age of all IPF patients, and certainly 46 is probably not what we'll see in IPF, but at least in familial disease, it seems that we may be able to pick these changes up very quickly. So, you know, the problem with familial pulmonary fibrosis is it's a very interesting disease, but the problem was it's relevant. So we wanted to see if there were other conditions in which we could find interstitial lung abnormalities, and so our next step was to study patients with rheumatoid arthritis. As you know, rheumatoid arthritis is a very common condition. There's like 1 million people in the US at one time that have rheumatoid arthritis, and we think that 30 or 40% of these individuals may have clinical or subclinical interstitial lung abnormalities. So it actually may be very important to look at this disease in terms of identifying these abnormalities. And in some individuals with which we did biopsies, there was mostly NSIP. It was, again, a limited number within the cohort. And again, smoking is very important. So if you look at subjects that are non-smokers who have rheumatoid arthritis, or at least this is the pack year smoking, there's a good correlation between this early phenotype and disease when you compare it to individuals who actually have a lower smoking history. So these individuals actually did not have interstitial lung abnormalities. These individuals have early changes, and these actually have a full-blown disease. The other thing that was very important for us, we got a lot of criticisms for our work, is that we don't know what's going to happen with these changes. Are these changes just transient? Are they coming and then disappearing? Or are these changes actually progressive? And so we had followed this cohort for 2.5 years, and what we saw is that in a subjective score, there was actually evidence of progression in a subset of the patients. So half of them actually tended to have progression in their CT scan. And what's really interesting is if you look at TGF-beta levels in the BAL, first of all, I'm a little bit surprised that we were able to measure it, but if you look at the levels in the lavage, they were significantly increased in the individuals with progressive disease, and here the N is 10 and 9, I think. And also we have found significant increases in the PDGF-BB isoform. So again, some molecular findings that suggest that this clinical phenotype is also correlated with some of the molecules that we think drive this fibrotic process. And Tracy Doyle is actually presenting an abstract in this meeting in which she's validated some of these findings in an independent cohort called the BRASS study at Brigham, and I won't go into detail. You can actually see the poster. The other thing that we were interested in looking at these individuals is it's going to be very difficult to actually do these research studies if we're going to leverage the thousands of CT scans that are going to become available now that we have screening for lung cancer. And so we're talking about 100,000 CT scans that are sitting in some files that we could potentially look at. So one of the questions that we had is, can we use these two cohorts to actually do some type of computed algorithm to detect interstitial lung abnormalities? And so this was the purpose of this work. And basically what I'm showing you here is that when we looked at the familial cohort and we compared the radiologist score with our computer score, there was some correlation between the severity of the disease and what the radiologist was able to subjectively score. And actually, when we did an independent validation of the computer score and the radiologist score in the subclinical interstitial lung disease group, actually we got a decent separation, suggesting that these automated computer algorithms may be able to classify the presence of these interstitial lung abnormalities. And I think from a clinical perspective, this is not important. But from a research perspective, I think it's going to be a very important tool to be able to effectively use all this data that's going to become available in the next decades. Again, there was a correlation with pulmonary function tests in these data sets. So, but again, I think we were very focused on finding it's relevant to IPF, and I've shown you that there's a theme of smoking. And so we thought looking at smoking with smokers was the next step. And as you know, depending on what study you look, 41 to 83% of patients with IPF actually have been former smokers. So we took advantage of a large cohort that exists at Brigham called the COPD gene cohort. At the time we did this study, we only had 2,500 subjects, but now there's 10,800 subjects that have been enrolled. And the follow-up 5-year study is already approved and funded, so we'll be able to actually do some follow-up on the changes that I'm going to be describing. So we had 2,500 individuals, of which almost 200 had interstitial lung abnormalities. And obviously this is a smoking cohort, so these are classified by gold stage as well. And let me just spend a couple of seconds showing you what the phenotypes we found, because I think this is very interesting. So what I'm showing you here on the top is a three-dimensional reconstruction of what we call RBILD, or centrolobular changes, that I think all of you are very familiar, and unfortunately it doesn't project well. But basically it doesn't have the subpleural distribution that you would classically see, for example, in IPF. But 50% of the cohort actually did have these changes. So half of these individuals, almost 100 individuals, had mostly subpleural changes. Then we had another percentage of individuals who had mixed patterns, and then we had a very small subset of individuals who actually had, it was really truly fibrosis, it's just that it had not been diagnosed. And again, one of the limitations of actually looking at this phenotype is there's really no correlation between pulmonary function tests and the actual phenotype. But when we actually did the analysis, the volumetric analysis of the CT scans, what we see is that when we're looking at total lung capacity and the frequency of participants, we can see that there's a shift, there's a reduction in volumes in the individuals who have interstitial lung abnormalities. And really the bottom line of the paper was summarized as this, is these interstitial lung abnormalities were present in about 1 of every 12 HRCT scans, and they were associated with reduced total lung capacity and lesser amount of emphysema. So these individuals that actually had fibrosis in these CT scans were, there was some overlap, but they didn't tend to be the same individuals that had the emphysema that were the original question in this study. And Tracy, once more, actually looked at the functional impact of these interstitial lung abnormalities, and she found that when you did unadjusted measurements of subjects with interstitial lung disease, there was a difference in 386 meters. And when you looked at only the subjects with interstitial lung abnormalities, there was an average walk of 386 meters and 486 meters with a reduction in 30 meters when it was unadjusted and 50 meters for subjects with ILA without COPD. So this is actually the first time we've been able to show that there's a functional impact of having these abnormalities, at least in smokers. And this is actually a graphic representation of this. So this is showing the percentage of subjects with a 6-minute walk distance that was less than 250 meters. And this is looking at all subjects and subjects without COPD. And so what you're seeing here is, in average, there's a greater percentage of individuals who have a decrease in their 6-minute walk. And it tends to be much more significant in individuals who have radiographic interstitial lung abnormalities or apparent fibrosis. And again, individuals with subclinical changes. And follow similar trends in the individuals without COPD. So I think none of us in the audience are actually surprised that smoking is associated with interstitial lung disease. I mean, basically people in the audience have written the papers and described this. And of course, aging is another of the common themes, both in terms of phenotype, and also we're learning that the process of aging biologically may be very relevant to the pathogenesis of fibrosis. But one of the things that was interesting to me when we looked at our data, and obviously this is not even interstitial lung disease, right? We're just talking about these interstitial lung abnormalities, is it seemed like BMI followed some of these findings. So what I'm showing you here is that the median body mass index was significantly associated with a phenotype. And we have to be careful because what we're looking at are CT scans, and these are not prone CTs. And so we may be just looking at the effect of BMI, but I think some of the people in the audience may be looking at this literature of metabolic syndrome because, as you know, in 2040, it's estimated that half of our population in the US is going to be obese. So I think at least we need to consider this question and see if this may be a modulator of the phenotype that we're looking at. So when we use BMI greater than 30, diabetes and hypertension, the odds ratio of having these abnormalities was 2.5. And when we adjusted, we had an odds ratio of 2.3. So these are actually significant, mostly in the individuals who have subpleural disease. So again, it's not the RB-ILD subjects, it's these individuals who have this radiographic pattern that suggests that they're going to develop one of the IIPs. And again, the odds ratio over here was 2.6. So I think this is at least interesting. And it's possible that obesity does play a role. And there's obviously in diabetes, there's an extensive literature that shows that dyslipidemia is associated with lipotoxicity. And this lipotoxicity actually can be a source of DAMPs. And we all know in the audience that these danger-associated molecular patterns drive some of the signaling processes that create fibrosis in IPF patients. So I think, again, one of the questions that we need to look a little bit more carefully, if you take this to the lab, you can take a mouse that is known to have an inability to handle lipids well, which is the ApoE model. And if you get the ApoE mouse, you give it bleomycin, this is what their survival looks like. And this blue line over here is an ApoE mouse that we're giving regular chow. And the overlapping line is a C57 mouse that actually we fed with high-fat chow for a month before we did the blue exposure. So again, some correlate in the lab that actually may say that this phenotype that we're seeing in these CT scans may have something to it. So let me just summarize our findings. Our group and others, our findings suggest that select groups at risk of developing interstitial lung disease have reduced lung volumes, increased respiratory symptoms, and reduced exercise capacity, which has not been recognized by either the subject or a physician. And for now, we've actually characterized these subjects, families affected with pulmonary fibrosis. There's a growing literature in connective tissue disease, and certainly there's a lot of interest in smokers. And I mentioned that there's some surgical literature actually showing that post-operative acute interstitial pneumonia or acute exacerbations in individuals who had asymptomatic disease. So, of course, much more work needs to be done. I think this work will be funded. The NIH is actually really interested in promoting research that will allow us to understand better this stage of the natural history of interstitial lung diseases. And I'll conclude by saying that although certainly there still remains some questions or many questions regarding the long-term prognostic implications of subclinical interstitial lung disease, this may represent an early disease stage for a subset of those who progress, and those are probably the ones we're going to have to focus on. So longitudinal studies will be required to better define the natural history of subclinical ILD and address some of the questions that we've talked about today. I think this is one of the issues that a lot of reviewers bring up with this work is while one may question the need to detect subclinical interstitial lung disease, really in the absence of effective therapies, why should you care? Why should you actually be looking at this if we don't have effective therapies? But of course, I think that we've made a significant amount of progress over the last decade in terms of identifying potential candidates and pathways that we can modulate. So it's possible that these novel therapies will prove most beneficial in these early stages, and we can actually try to do some secondary prevention. And finally, I think that I have not gone into detail. There's other models in the lab that we're looking at, but some of these clinical findings I think may improve our understanding of the pathogenesis of pulmonary fibrosis. And of course, this work is done by many people. At Brigham, Hiroto Hatabu in the radiology department and Matt Honeyhake have actually been instrumental in this work. Ed Silverman is the PI of the COPD gene cohort. Tracy Doyle got her first grant yesterday to actually look at subclinical interstitial lung disease in RA, and George Washko is a superstar that actually looks at imaging in COPD. I started this work in Bernadette Cochico's lab, and Jack Zhao, who's a physicist at NIH, did some of the work that allowed us to show the computer algorithm-derived data. And of course, a lot of what I've presented today has to do with Naftali's creativity. So I want to thank everybody, and I'll take some questions.
Start with the lung macrophages for a second in smokers, right? Because, you know, cigarette smokers have, 10 to 100 times more alveolar macrophages in their air spaces than non-smokers, including in the interstitial space. So this sounds a story having to do with the lungs' limited response to injury. So you can have injury from cigarette smoke through macrophages. You have obviously injury in when you have metabolic alterations with BMI and things like that. So what I'm asking is, how does one approach when we know that the lung macrophages in smokers are so altered and they're there in huge numbers, it's not a surprise that there's interstitial fibrosis in these people. So what do you do?
Correct. So I think I'll make two comments. I mean, I completely agree. And again, a lot of reviewers, which I'm sure are sitting in this room today, actually brought this up as a very important point, which is for 30 years now, you've shown some of the pathologic changes, and a lot of folks have described some radiographic abnormalities that are associated with this, and it's just a smoking effect. And that doesn't mean that these individuals are going to develop IPF or any of the other interstitial idiopathic pneumonias. So I think that I'll start by saying that I agree with that. I acknowledge that the phenotype that we're looking at, all these individuals will not develop IIP. The question is, can we identify a subset of individuals that is different from these individuals who have macrophage infiltration, which my knowledge of the literature suggests that this is a more homogeneous pattern, this dirty lung pattern, maybe a more homogeneous pattern than what we've described. And that some of these subpleural changes, at least in a subset of these patients, may be different. And so if we accept that, then what we need to really do is focus on that subset or others that may be interested and see which is the subset that actually progresses. And I think that Of course, I'm not sure that the NIH is willing to fund 20 years of research, but we do need to actually have the longitudinal studies like COPD gene and other smoking cohorts to actually be able to address this question. So I think that I acknowledge the limitation of the research. I agree that some of this may actually be a innate immune response to smoking, not only smoking, but other of the environmental insults. But again, the reason why we're doing the research is we don't know what subset of individuals who have these environmental insults will respond by developing pulmonary fibrosis. So Matt Honeyhockey, I know, is collaborating with Marvin and David in a project in which they're actually looking at the MUC5B mutation and seeing if there's a correlation or association between this mutation and developing interstitial lung abnormalities. So it will require a lot of tools. It will require genetic tools. We'll have to do phenotyping in the alveolar space. We'll have to do phenotyping in the peripheral compartment. But I think all of this will really not answer the question. The question will be answered only when we're able to follow these individuals for a long period of time. So have any of these studies been done? So Sohail El-Kamali, when he was at the NIH, actually looked at a family, two sisters who had been followed for 30 years, and they're still alive. Some of the changes have been progressive. So maybe you shouldn't care because, for example, where we have the strongest data, it seems like there's a subset of individuals in which the disease is not as aggressive as we think we are. But we've all taken care of IPF patients, familial pulmonary fibrosis patients who have very rapidly progressive phenotypes in which this may become relevant. So this is the tip of the iceberg, and I think a lot of tools will have to be, come together for us to be able to successfully use the phenotype.
Would the question, people asking questions, identify themselves, please?
Yes. Molteni, Kansas City, Missouri. At poster number 60, I show a cohort of mice, obese mice with leptin knockout. It's quite interesting that those mice, tremendously obese and diabetics, show a significant inflammatory reaction in the lungs, corrected partially by TGF-beta treatment, but no evidence of vasculitis or fibrosis. There is only a very large periadventitial edema in the small vessels of the lungs. On the other hand, in the liver, in the pancreatic fat and the peripancreatic fat, we see inflammation, we see some severe vasculitis, and we see severe increase in fibrosis in the portal triads and the pancreatic ducts. I'm really chagrined by this dissociation in those animals. Their leptin knockout receptors are not measurable practically. Thank you.
I missed the question, but I love the comment. I'm very encouraged by your work because, as you know, as you can see, we're working with the ApoE knockout mouse. And I think I'd like to point out some of what you said is very important, which is one of our limitations in terms of concluding the relevance of lipid toxicity in the animal model is that we're using the constitutive ApoE knockout mouse. And so what we're modulating at that time, or the effects that we're seeing when we actually study the mouse, probably have to do more with inflammation than fibrosis. So we're lucky that we've been able to obtain a conditional ApoE knockout mouse from a collaborator at the NIH, and hopefully within the next year or so we're going to be able to do some exposures to see if modulation of lipid biology actually plays a role in lung injury and repair. But for me, it's striking to see that you can actually give McDonald's to a mouse for a month only, and their response to lung injury is dramatically different. I mean, the outcome is death. So I think there's something to it. I think we should be excited by the fact that there's some correlate in the epidemiologic data that I showed. So I think we need to look carefully at this question. It may be relevant.
Question? Yes.
Yeah, Ulrich Kostabel is in Germany, also rather more a comment. So maybe ages ago, 20, 30 years ago, we also defined subclinical ILD based on BAL findings. A very good example is the large group of dairy farmers studied by Yves Cormier in Quebec, and he followed them every 10 years, made a new publication, and he found that there are individuals being exposed at the farms having BAL lymphocytosis. Most of them are also precipitants, and they never progress to fibrosis, but they just stay in this state for ages, just as a comment. Huh?
Correct, and I appreciate the comment, and it's, I guess, high risk, high impact. We may be following these individuals for decades and may come to the same conclusion that you did, that these abnormalities are not important. So we'll have to wait and see.
Okay, no further questions. Thank you very much.
Thank you, Martin.